You are welcome to this session. My name is Dr. Adudoju Odushola Peter from the Department of Obstetrics and Gynecology of Ekiti State University, Ado-Ekiti, Nigeria. I'll be taking you lecture on endometriosis and adenomyosis. At the end of this session, I expect you to be able to define endometriosis, to understand the basic pathogenesis of endometriosis, know the types, classification, and site of endometriosis, know the presentation of endometriosis, and also how to investigate endometriosis and the various treatment modality of endometriosis. The lecture outline will follow this pattern: introduction, site, etiology, theory for endometriosis, clinical feature, classification, pathophysiology, diagnosis, and management. By way of introduction, endometriosis is a benign gynecologic condition that is poorly understood. It was first described by von Rokitansky in 1860. This disease is an extremely debilitating one that is associated with chronic pelvic pain and also poorly understood. It is defined as the presence of normal endometrial mucosa, gland, and stroma that is abnormally implanted in locations other than the cavity of the uterus. By way of epidemiology, the exact prevalence is unknown, but there has been a rise in prevalence of this disease because of increasing awareness and also diagnostic modality. It is estimated that in Caucasian, it is found in about 15 to 30% of patients undergoing laparotomy and hysterectomy. It is less common in Negroes, in blacks. In fact, a study done in Zaria, Nigeria, reported a prevalence of 8.2%. It is commoner in people of high social class, highly civilized society, and of course, it affects women of reproductive age group. The etiology is unknown, but there are risk factors that have been associated with this disease. Family history: there is a 7-fold increase in female of women who suffer this disease. First degree relative, there is a 7-fold increase of risk of that female developing it. And then increased exposure to menstruation. Women who have a long period of exposure, who undergo menstruation for a long period, are at a risk of developing this disease. So people who had early menarche and late menopause, women with short cycle, that is less than 27 days, women with long duration of menstrual cycle, longer than 7 days, women with heavy menstruation, and those who are delayed childbearing or low parity. This group of women will be exposed to a longer period of menstruation. Then social habits. Habits that increase the estrogen level have been found to predispose women to develop endometriosis. So people that consume caffeine and alcohol. However, there has been found a reduced risk in women who use oral contraceptives and those women who also engage in lifestyle that reduce estrogen level. These people who smoke and do regular exercise. Pathogenesis. The exact cause and pathogenesis of endometriosis is unclear, but there have been theories that have been propounded to explain how endometriosis comes about. And this theory includes retrograde menstruation, syndromic metaphyseal, vascular and lymphatic dissemination, immunologic dysfunction, and hereditary factor. Retrograde menstruation. This was first propounded by Sampson. And in this theory, there is reflux of fragment of endometrial cells or tissue through the fallopian tubes into the peritoneal cavity during menstruation. This endometrial fragment gets implanted in the peritoneal surface of the pelvic organs and with hormonal support, those tissues continues to grow in this site. And that is why women who have defect in uterus with outflow obstruction and of fallopian tube are predisposed to developing endometriosis. The second theory is syndromic metaplasia theory. In this theory, terminal epithelium of ovary, endometrium, and peritoneum originate from the same syndromic epithelium. And so this cell can transform to endometriotic lesions wherever they are found in response to appropriate stimuli, either hormonal stimulation or infectious stimuli. And this accounts for presence of endometrial tissues in distant sites. The third theory is lymphatic or vascular theory. There is dissemination of endometrial cell or tissue into the peritoneal cavity and other extrauterine sites through the blood vessel and lymphatic channels, or by contamination of the pelvis, or through azogenic dissemination in scars during cesarean section or other pelvic surgery. The fourth theory is hereditary factor. It has been found that women that have the family history of the disease, usually first degree relative, they have a 7-fold higher risk of developing endometriosis. The mode of inheritance has been found not to be to follow the Mendelian inheritance pattern. So it could be polygenic or multifactorial in origin. The last theory is immunologic theory. In this theory, it has been found that there is altered and impaired immune response to retrograded endometrial tissues because of decreased lymphocyte cytotoxic response to endometrial cells. And because of this, there is inability of the body to clear the displaced endometrial tissue. And this leads to ectopic development of the endometrial fragments, wherever they are found. Pathophysiology. Endometriosis is an estrogen-dependent disease. So ectopic endometrial tissue are independent portion of the female reproductive system. And this tissue respond to cyclic hormone. And this leads to peritoneal inflammation that causes pain, adhesion, and anatomic distortion, which eventually lead to other clinical consequences that may be found in women who suffer from endometriosis. The site of endometriosis includes, most commonly it is found in the abdomen, and the most common site in the abdomen involves the ovary in about 44% of patients. It can also be found in the pouch of Douglas, rectovaginal septum, uterosacral and broad ligaments, and even in the pelvic nodules. The rare sites in the abdomen include the gut, the appendix, ureter, and urinary bladder. The extra-abdominal sites. The common extra-abdominal sites include the abdominal scar of hysterectomy, cesarean section, mammectomy, and sapingectomy. It can also be found in the umbilicus, episiotomy scar in the vagina and the cervix, where the rare extra-abdominal sites include the pleura, the lungs, the thigh, and the deep tissues of the arms. This is anatomy of normal female pelvis, and so endometriosis can be found in any of the structures that are displayed in this slide. And this is also showing the various endometriosis spots. The blue spots represent the endometriotic lesions. So we can see that it can be found, virtually anywhere within the abdominal cavity. And this is also some lesions, found on the cervix. How does this present? The symptom of endometriosis could vary. It could be asymptomatic, in which case it is found accidentally during investigative procedure like laparoscopy. and this accounts for about 1/3 of patients presenting with endometriosis. And then it could be symptomatic. And when it is symptomatic, the symptoms include pelvic symptoms, which are dysmenorrhea, usually secondary dysmenorrhea, that the pain starts 1 or 2 days before menstruation starts and persists, during menstruation before it resolves. And this accounts for about 60% of patients that present with endometriosis. They can also present with abdominal vaginal bleeding, like menorrhagia, intermenstrual bleeding, and this is also found in about 50% of patients that present with endometriosis. Deep dyspareunia and chronic pelvic pain are also symptoms that they can also present with. The GI symptoms, gastrointestinal symptoms, these include bloating, nausea, vomiting, constipation, diarrhea, tenesmus, and hematochezia. They can also present with urinary symptoms like flank pain, back pain, abdominal pain, urgency, frequency, hematuria. Pulmonary symptoms include hemoptysis, pneumotoria. So they can usually come down with symptoms depending on where these lesions are found. So it can affect all the system depending on where they are found. And then commonly they may also present with infertility. And in them, when they present with infertility, it could be due to one, mechanical interference. Because of the inflammation, fibrosis, this leads to pelvic adhesions and causes distortion of the tube, and then tubal motility is also affected, and this will affect transport of sperm and ovum through the fallopian tube. Then the second way by which it can cause infertility is when we have alteration in peritoneal fluid with increased prostaglandin, macrophages, and cytokines. Then it has also been found that there is abnormal systemic immune system, and this leads to formation of antibodies that can cause destruction of sperm cells. And then the fourth way by which they can cause infertility is hormonal and ovulatory dysfunction. It has been found that some of them may have luteal phase deficiency, implantation failure. All these will lead to infertility in this group of patients. Signs that can be found in patients with endometriosis include, generally when they are examined, depending on the degree of hemorrhage from menorrhagia, intermenstrual bleeding, they may come down with pallor. Otherwise, there may not be any significant finding on the general physical examination. The systemic examination, the vital signs, pulse pressure, pulse rate, blood pressure may be normal. Where the major signs may be found is in the abdomen, and of course, examination of the abdomen may also not reveal anything. This pelvis may be normal, but again, one can also find mass in the lower abdomen arising from the pelvis. Then there will also be enlarged, the ovary may be palpable due to enlarged Sokolove cyst, and this may present typically as a tubal ovarian mass. On bimanual pelvic examination, one may be able to feel tender uterosacral ligaments. One may also palpate nodules in the uterosacral ligaments, and then there is fixed retroversion of the uterus due to adhesions, and then adnexal mass, which may also be tender, can also be palpated on bimanual pelvic examination. Diagnosis and staging. We have mentioned the symptoms that the patient will present with, and then we also highlighted some of the signs that may be found on examination. By way of investigation, investigations that will be done in endometriosis include laparoscopy. This is visual inspection of the pelvis using laparoscope. And this will afford one the opportunity to see the endometriosis spot, the lesions, wherever they are, either on the surface of the ovary, on the peritoneum, intrasacral ligaments, endovaginal symptoms, wherever the lesions are found can be visualized on laparoscopy. And laparoscopy is a gold standard in diagnosis of endometriosis because it will afford one the opportunity to visualize these lesions. And the findings will include a typical powder-borne or gunshot lesions, which may be black, blue, or dark brown, in color. Or one may find a cyst with old hemorrhage surrounded by fibrosis on the serosal surface of the organs, on the ovary, or the peritoneum, depending on where the lesion is found. And this is showing laparoscopic examination, and we can see these lesions and where the endometriosis spots are described, on the surface of these organs, as shown by laparoscopy. Then one may also find ovarian endometriosis cyst, which contains a thick, viscid, dark brown fluid that is typically called chocolate fluid. So that is characteristic of ovarian endometrioma. And when this is found, biopsies can also be done during laparoscopy. This slide is showing typical endometrioma, on the surface of the ovary. You can see the chocolate cyst, on the surface of the ovary. One can also do a transvaginal or transrectal ultrasound. This will help in diagnosis of ovarian endometrioma. CT and magnetic resonance imaging can provide additional and confirmatory information, but they cannot be used for primary diagnosis. One can also assess CA125 level, which is seen in about 80% of women with endometriosis. But this is not a reliable screening test, as it can be found in other conditions. This slide is showing the classification of endometriosis using the American Fertility Society revised classification system. And this is what is used in scoring a patient that may have endometriosis, based on the findings at laparoscopy. And the stage is determined by the total number of points assigned to endometriosis lesion and additions. So we have stage 1, which is minimal. That is, point is between 1 to 5 points. Then stage 2 is mild with 6 to 15 points. Stage 3 is moderate with 16 to 40 points. And stage 4 is severe when the patient had greater than 40 points. So this is what is shown on this second slide. We have stage 1 minimal, and also corroborate the previous slide. Management. Treatment of endometriosis could be medical or surgical. And the choice of treatment depends on 1, the age of the woman and the fertility patterns, previous treatment, location and severity of disease, and nature and severity of symptoms. So treatment options could be expectant, and then it could be symptomatic treatment. Expectant, especially if the woman is perimenopausal, since endometriosis is estrogen dependent. One expects that as menopause approaching, with declining level of estrogen, the symptoms may gradually resolve. But if the symptoms become severe during expectant or watchful waiting, then one may also decide to treat either medically or surgically. So symptomatic patients are treated either medically or surgically. Medical treatment. The goal of this medical treatment is to alter the menstrual cycle and then produces a state of pseudo-pregnancy, pseudo-menopause, and chronic anovulation, such that there will be a reduced level of estrogen that will be available in the system, and that ameliorates the symptoms that the patient may present with. Then it also impairs growth and maintenance of endometriotic lesions, since those lesions are starved of estrogen, and so it impairs their further growth, and then so eventually it suppresses the implant, but it does not remove them. They gradually atrophy, even though the spot may still remain there. So the medical treatment that can be used include non-steroidal anti-inflammatory drugs, NSAID. And what this does is that it leads to high peritoneal and tissue prostaglandin, and this can help to ameliorate the pain that women with endometriosis usually have. Apart from NSAID, we can also use hormonal agents, which either combined agents, progestogen and antiprogestogen, gonadotropin releasing hormone agonist. Progestogen, what this does is that it suppresses ovarian cytogenesis and causes glandular atrophy. And it also opposes the growth-promoting effect of estrogen on the endometrial tissue, since endometriosis is estrogen sensitive and dependent. So progestogen opposes the effect of estrogen on this endometrial tissue. Then progestogen also prevents reflux menstruation, so that endometrial tissue, endometrial glands are not washed into the peritoneal cavity. They also prevent implantation and growth of regurgitated endometrium, since they oppose the effect of estrogen on this tissue. And progestogen that can be used include progesterone acetate and cyproterone acetate. The side effects of using progestogen include weight gain and edema and irritability. The second medical agent that can be used is gonadotropin releasing hormone agonist. This includes nafarelin, niprolide, buserelin, and goserelin. This agonist stimulates luteinizing hormone and follicular stimulating hormone synthesis and release, such that it suppresses ovarian steroid production, causing a state of pseudo-menopause. There's an initial flare that later suppresses the production of this LH-FSH from the higher center, and that leads to a suppression of production of estrogen and progesterone, so causing a state of pseudomenopause. And in that way, it will lead to atrophy and regression of the endometriotic spot. Side effects of long use of GnRH agonists include hypoestrogenism, hot flushes, osteoporosis, and vaginal dryness. This effect can be mitigated by doing an hormonal add-back therapy or using this agonist for a short period, less than 6 months. Other medical agents that can be used in treatment of endometriosis include danazol. Danazol causes a direct inhibition of release of gonadotropin releasing hormone, and thereby impairing steroidogenesis. It also causes increased metabolic clearance of estrogen and progesterone, such that the level of estrogen is kept low in the system, thereby depriving the endometriotic lesion estrogen support. The side effects of danazol include weight gain and muscle cramp. We can also use aromatase inhibitor. Example of this is letrozole and vorosol. What this does is that they interrupt the local estrogen formation. Local estrogen production is impaired, and therefore shorten the lesion's supply of estrogen, and which will eventually lead to atrophy and regression of this endometriotic lesion. And side effects of use of aromatic inhibitor include bone loss and then multiple cyst formation. Apart from medical management, one can also treat the patient surgically, and the goal of surgery is to excise all visible lesions, because as long as lesions is there and there is hormonal support, hormonal stimulation, the patient will keep coming down with the symptoms of endometriosis. So at surgery, the goal is to excise all visible lesions. And then for those who have not completed their family, one wants to preserve the reproductive function, which is highly essential to them. Surgery could be conservative or definitive, depending on the age of the patient. For conservative surgery include laparoscopic adenolysis and resection of lesions. And then one can also do laparotomy for extensive disease. And during laparotomy, adenolysis, tuber repair can also be done. And one can also go as far as doing a presacral neurectomy, to mitigate the pain that this patient represents with. So as I've said, the surgical management, the goal of surgery is to excise all visible lesion, to preserve productive function, and surgery could be conservative or definitive. For conservative surgery, this can be done laparoscopically, and at laparoscopy, one can insert the lesion and then do adenolysis, as the case may be. And then apart from laparoscopy surgery, one can also do open laparotomy, really for extensive disease that one cannot take care during laparoscopy. And at laparotomy, adenolysis, tuber repair can be done, and then one can also go as far as doing presacral neurectomy. The definitive surgery, especially for patients who has completed their family or with very debilitating disease, with chronic pelvic pain, is total abdominal hysterectomy and bilateral salpingo-oophorectomy. One of the common complications associated with endometriosis is infertility, and the treatment for this is assisted reproductive technique. They are very effective in the treatment of infertility associated with endometriosis, and this will include ovulation induction alone with clomiphene citrate, as the case may be, or ovulation induction with intrauterine insemination, or in vitro fertilization and embryo transfer. All these are modalities that one can use to manage endometriosis, manage infertility associated with endometriosis in this patient. And it has been shown that endometriosis has not reduced the success of in vitro fertilization. As we round up, we look at adenomyosis. This is also called uterine endometriosis and is regarded as a separate disease entity from endometriosis. Again, in adenomyosis, endometrial tissues are found within the myometrium, and is also commonly observed in women of reproductive age. Etiology is unknown, just like endometriosis, and has been found to be commoner among the Caucasian. Clinical features include symptomatically they present with menorrhagia, with progressive secondary dysmenorrhea. They also have deep dyspareunia and with pelvic discomfort. They can also present with backache. On examination, there is symmetrical enlargement of the uterus, which may also be tender. Management, diagnostic hysteroscopy combined with curettage. And an examination, the uterus is symmetrically enlarged. Symmetrically enlarged. Unlike uterine myoma, that you have a regular enlargement of the uterus. This is one of the ways whereby one can differentiate uterine fibroid from adenomyosis. The uterus is symmetrically enlarged. And then on histology, one will find island of endometrial gland surrounded by stroma on histology. Management will involve the use of drugs, non-steroidal anti-inflammatory drugs, hormonal agents like danazol, gonadotropin releasing hormone analog, as we have mentioned in endometriosis. They can also be used for adenomyosis. And then surgically, the treatment is using total abdominal hysterectomy and bilateral salpingo-oophorectomy. Complications of endometriosis will include infertility, which we have mentioned, then chronic pelvic pain. They can also have frozen pelvis, and which can also cause infertility, as I mentioned earlier. Thank you for listening.